Hello friends, today's topic is invasive candidiasis. Invasive candidiasis affect more than 250,000 people worldwide every year and is cause of more than 50,000 deaths. Incidence rate of candidemia have been reported to be between 2 and 14 cases per 1 lakh person population based studies. So the candidemia is the fourth most common bloodstream infection. The incidence of candidemia is age-specific with maximum rate observed at extremes of age. So we'll see what are the risk factors for candidiasis. Critical illness with the particular risk among patients with long-term ICU stay, any abdominal surgery with particular risk among patients who have anastomotic leakage or have had repeated laparotomies, acute necrotizing pancreatitis, hematological malignant disease, solid organ transplantation, solid organ tumors, neonates, particularly those with the low birth weight, preterm infant using broad spectrum antibiotic, presence of central venous catheter, total parental nutrition, hemodialysis, glucocorticoid use, chemotherapy for cancer, candida colonization, particularly if multifocal, like colonization index is more than 0.5 or corrected colonization index more than 0.5. So now we'll see what is the pathogenesis of invasive candidiasis. So Candida species has colonized the gut invade through translocation or through anastomotic leakage after laparotomy and cause either localized deep-seated infection like peritonitis or candidemia. So in patient with the indwelling intravascular catheter, candidemia that originate from the gut or skin, it leads to the colonization of catheter and formation of the biofilm. So fungi are subsequently released from the biofilm and will cause persistent candidemia. So once candidemia has developed, whether from colonized intravascular catheter or by other means, the fungi may disseminated, leading to the secondary metastatic infection in lung, liver, spleen, kidney, bone, or eye. These deep-seated infection may remain localized or lead to secondary candidemia. So during candidemia, fungi in bloodstream may enter urine, leading to candiduria. Less frequently, this deep-seated candidiasis may occur as a result of ascending pyelonephritis and may either remain localized or lead to secondary candidemia. So this is a diagrammatic representation of pathogenesis of fungus, fungus. First, the candida colonizing in the gut, like peritonitis or candidemia caused by the surgical anastomotic leakage or translocation, or any candidal infection from the skin is responsible for the candidemia. So these candida will invade the intravascular catheters. It will lead to the formation of the biofilm, and from there it will get disseminated into the multiple organs like spleen, liver, eyes, lungs, and in bones, also in the kidneys. So the Candida species distribution has changed over the past decades. So the most common is the Candida albicans, has been the dominating pathogen nowadays. This species account only for half of the isolate detected in the map. Now the Candida glabrata has emerged as important pathogen in Northern Europe and United States and Canada. Candida parapsilosis is most prominent in Southern Europe, Asia, and South America. So these Candida species differ considerably in the virulence also. Candida parapsilosis and Candida krusei are less virulent. Candida albicans, tropicalis, and glabrata are more virulent than these two species. So Candida parapsilosis is associated with the low mortality. Candida krusei is highly uncommon except in patients with severe immunodeficiency and prior exposure to azote. So, despite its low virulence, Candida parapsilosis can thrive in certain clinical settings, owing its ability to adhere to medical devices and its propensity to colonize human skin, which is these two qualities are responsible for the nosocomial outbreaks. So, immunogenetics of candida infection. Now, why it is necessary to know about this immunogenetic part? Because the majority of the patient in the ICU do not acquire invasive candidiasis even if they share say, similar risk factors. This is because the variation in the genes makes certain patients more prone to candida infection. So the susceptibility to the candidemia was increased in patients who had this single nucleotide polymorphism in toll-like receptor uh, 1 interferon gamma pathway. So what happens is the patient in the ICU who carried two or more allele at this particular loci had risk of candidemia that was 19 times more as high as the risk among patients who did not have these alleles. So disease progression in the persistent candidemia despite antifungal therapy was associated with the cytokine polymorphism that led to either increased circulating level of anti-inflammatory interleukin 10. So the decreased level of the pro-inflammatory interleukin 12B cytokine. So the identification of this specific allele related to the risk of disease and of cytokine pathways associated with the unfavorable outcomes. Screening strategies based on the presence and absence of certain SNPs may help to identify patients at risk who could benefit from the prophylactic antifungal treatment or adjunctive immunotherapy. Invasive mold infection caused by aspergillosis are not uncommon among critically ill patients. So, the invasive aspergillosis was considered to be the disease seen mainly in neutropenic patients and in hematopoietic stem cell transplant recipients. Invasive aspergillosis is an important pathogen in critically sick patients without neutropenia, such as those receiving immunosuppression therapy, those suffering from any chronic organ system failure. Aspergillosis are commonly found in sinonasal disease or chronic pulmonary disease and also in dermatological or CNS infection. Outbreaks of aspergillosis has been usually associated with the faulty air filtration, construction or work material, and even medical equipment as infection usually start from inhalation of candida. So diagnosis of invasive aspergillosis is particularly challenging in critically ill patient because typical radiological feature like that is a halo sign are not usually seen in non-neutropenic individuals. Such a patient do not progress rapidly to angio-invasive disease frequently. Invasive aspergillosis is associated with the significant high mortality to the extent of 65% to 85%. So the mold causing disease among the immunocompromised patients are Cryptococcus, Fusarium, Pseudosporium, and Mucormycosis. These infections more frequently occur among individuals on long-term immunotherapy for various rheumatological and other chronic diseases. Invasive aspergillosis and mucormycosis have been frequently seen recently among patients who were infected with the COVID virus and treated with high dose steroid and who were diabetics. So the methods available for diagnosing candidemia are direct and indirect. Direct method in which specimen of the blood and tissue from sterile area are cultured, and indirect detection in which surrogate markers and polymerase chain reaction assays, that is PCR assays are used. So marker for fungal infection is Candida menin antigen and antimenin antibody and BD glucan are primary surrogate marker for invasive candidiasis. BD glucan diagnostic test. It has a good negative predictive value of 80%, thus making it a valuable tool to avoid inappropriate antifungal use. Mannan is specific to Candida species and is a polysaccharide component of fungal cell wall. Latex agglutination and enzyme immunoassay methods exist for both Mannan antigen and anti-Mannan antibody. These tests are more specific than BD glucan test, but not as sensitive and do not become positive until later in the course of disease. So it is seen that sensitivity of this test vary based on the Candida species, with high sensitivity reported for Candida albicans and the lowest for Candida parapsilosis and Candida krusei. So the galactaman is the specific assay for aspergillus. The positive predictive value of this assay is relatively weak in non-neutropenic ICU patient and solid organ transplant recipient. Non-neutropenic patient may show false negative test result because of the slow progression to the angioinvasive disease. False positive results may occur when administering beta lactams like piperacillin tazobactam or plasma. So the test can be performed from bronchoalveolar lavage specimen, which tend to increase both sensitivity specificity over serum values. Now the next is blood culture. Now the sensitivity of the blood culture is 21% to 71%. Blood culture may establish diagnosis during period when candidemia resides in the bloodstream. In case of hematogenous deep-seated infection, blood culture yield negative result because candida has been cleared from the bloodstream at the time of the blood culture is collected. So the positive blood culture result may be relevant only in the late course of the disease. Positive blood culture should prompt immediate initiation of the therapy and search for metastatic focus. PCR tests for the detection of invasive candidiasis have been evaluated. In-house PCR assay had sensitivity for 89% for deep-seated candidiasis. Two commercial PCR assays have been marketed, Septifast and fully automated multiplex T2 Candida panel. Now, prophylaxis in view of high mortality associated with invasive candidiasis, prophylaxis for selected patient in ICU who are at high risk for the disease would appear to be appropriate. Antifungal prophylaxis has generally shown trend towards reducing incidence of candidemia by approximately 50%, but this strategy has not shown to improve survival. So the major challenge is to select individual patient or subgroup that will actually benefit from prophylaxis. So antifungal for prophylaxis should be limited to the patient in whom it has proved to be beneficial. Like in patient with the gastrointestinal anastomotic leakage, patient undergoing transplantation of pancreas or small bowel, selected patient undergoing liver transplantation who are at risk for candidiasis, and extremely low birth weight neonates in setting with high incidence of neonatal candida. Fluconazole prophylaxis has been shown to be effective in patients who have had recent abdominal surgery, have a recurrent gastrointestinal perforation or anastomotic leakage. Early treatment. Now, when to start early treatment? So, early presumptive antifungal therapy is based on the symptoms and biomarkers. So, the prediction rules like Candida score and non-culture based test might be the best viewed as markers to determine the possibility that patient has invasive candidiasis. Now we'll quickly see what is a Candida score. It is based on the following risk factors like surgery upon admission. It carries 1 point. Total parenteral nutrition carries 1 point. Severe sepsis carries 2 point. Multifocal colonization carries 1 point. If this Candida score is about 2.5, then that indicates the high risk patient who might benefit from the antifungal prophylaxis treatment. Now, what are the antifungal drugs? We'll see that and the classification. Now, it is divided under like antibiotics, which includes polliens, that is amphotericin B, nystatin, echinocandin, which includes capsofungin, micafungin, anidulafungin, and heterocyclic benzofuran, that is brucifolin. Then second class is antimetabolites, which include flucytosine. Then azoles like imidazole. Topical azoles includes clotrimazole, iconazole, miconazole, and oxyconazole. Systematic azole includes ketoconazole, trizole, fluconazole, itraconazole, voriconazole, posaconazole, and allylamine, that is terbinafine. So amphotericin B, it binds to the ergosterol, that is the principal sterol in the fungal membrane. It impairs the membrane function to the point of causing leakage of cellular content. The ergosterol molecule of the fungi has cylindrical three-dimensional structure. The major sterol in the mammalian membrane, which has the sigmoid shape. The binding affinity of the amphotericin B for ergosterol is greater over cholesterol. So this is picture which showed the mechanism of amphotericin B. So as we can see, this amphotericin B interacts hydrophobically with the ergosterol in the fungal cell membrane, forming pore. And through that pore, the potassium and the small molecules are lost, which causing the cell death. So amphotericin B is a toxic to the mammalian cell. Particularly, it causes nephrotoxicity. To overcome amphotericin B toxicity, variety of reformulated version of agent have been introduced. They probably reduce the nephrotoxicity by slowing the rate at which amphotericin B is delivered to the kidney. The most successfully clinically proven version of novel formulation are based on lipid combination of amphotericin B, which is encapsulated in the liposomes and the ribbon-like, disc-like lipid complex. Other formulations are under investigation, like amphotericin B cochleate preparation and arabinogalactone complex. Other class is antifungal azoles, which include imidazole and triazole, are the largest class of antifungal agent in the clinical use. Their main effect is to inhibit 14-alpha demethylation of lanesterol in ergosterol biosynthetic pathway. And so this cartoon showed the mechanism of action of azole. As we can see, the lanesterol is converted into ergosterol, which helps in formation of fungal cell membrane. And this azole is acting on this 14 alpha demethylase, which stops the conversion of lanesterol to ergosterol, and it impairs the formation of fungal cell membrane. So first generation triazole agent is fluconazole has the good overall activity against Candida species and Cryptococcus neoformans. However, resistance to the drug is encountered in certain non-albicon Candida species like Candida krusei and some isolate of Candida glabrata. It is also available as oral and the intravenous formulation. Itraconazole has the activity against the yeast and some molds, but is disadvantaged by variable viability and the unpleasant taste. Now, second generation triazole agent, voriconazole and posaconazole are the second generation triazole with extended spectrum activity against yeast, Candida neoformans, molds, including Aspergillus, Sporosporium, and the Fusarium species. Voriconazole is active against fluconazole-resistant Candida species. Voriconazole is also available for intravenous use. Voriconazole is administered twice daily, and adverse effect of this is Steven Johnson syndrome, hair loss, electrolyte disturbances like hypokalemia, cardiovascular effects like QTC prolongation, arrhythmias, uh, then hallucination and visual disturbances. Now, next drug is posaconazole, which was licensed in May 2007, and it has a broader spectrum azole to date. So it is the only azole with the clinical activity against the zygomycete fungi. It is usually prescribed initially in 4 divided doses to achieve the adequate plasma level, but may be given twice daily in non-life-threatening situations. Its absorption is improved when taken with the food and the nutritional supplements. Now, the adverse effect of azole in general, triazoles are relatively safe, even when used for the prolonged period. All triazole cause hepatotoxicity, but only 5% to 7% patients require the treatment cessation. Hepatic reaction ranges from the mild transient elevation to transaminase to clinical hepatitis, cholestasis, and liver failure. The most clinically significant interaction occur with the rifampicin, where concomitant use of itraconazole, voriconazole, posaconazole is contraindicated. So when possible, rifampicin should not be used in conjugation with the fluconazole. Now, the next class is echinocandins. The target for echinocandin is the complex of protein responsible for synthesis. Protein, it will hamper the formation of the cell membrane. So all three showed good in vitro activity against the Candida and the Aspergillus species, but not active against the Cryptococcus neoformans and non-Aspergillus molds. It is also effective as a salvage therapy for invasive aspergillosis, but as yet to be evaluated for primary treatment of the mold infection. So the echinocandins has good penetration into tissue, but the CSF level are low. So caspofungin is available as intravenous formulation. Owing to the long half-life, it can be administered orally once daily. The recommended dose is of caspofungin is 70 mg loading dose followed by 50 mg daily. Dose adjustment is required in the dose adjustment in renal impairment is not required. However, moderate hepatic insufficiency dose reduction is recommended. After initial loading dose, the subsequent daily dose should be 35 mg. The toxicity associated with the echinocandins are rare. Adverse effects include histamine release reaction, irritation at infusion site, headache, and rash and fever. Now the catheter removal. Concept supporting removal of intravenous catheter in patient with candidemia is based on identification of catheter as a major risk factor for candidemia, the presence of biofilm of candida species attached to catheter, and observation that candida may persist until catheter has been removed. Treatment with the echinocandin and catheter removal were identified as the two modifiable management strategies associated with the better survival. So we'll see the overview of this fungal candida treatment. So if you are suspecting invasive candidiasis, then we have to obtain the blood culture and we have to send the two consecutive BDG levels. Now after that we should look for the multiple risk factors and better to calculate the candida score. If the candida score is more than 3, then we have to start with the echinocandin if the patient is unstable. Consider fluconazole in the unstable patient. If candida score is not more than or equal to 3, and if you are not clinically, if you are not suspecting invasive candidiasis, then do not start any antifungal therapy. Then we have to wait for the blood culture and BDG results for 2 to 5 days. If blood culture is positive or a BDG is positive, then continue with the echinocandins and fluconazole in a clinically stable patient. If negative, then discontinue antifungal therapy that we have started, and we have to treat this fungal infection at least for 14 days, and we can consider the de-escalation to fluconazole after 5 days. Thank you, friends.